Christian's here, yay.
Wonderful. Welcome to those that are joining this week's, I guess, our Young Professionals Chronic Disease Network's mini-series on pain and palliative care. And our excitement at the beginning of this call, our guest for the next session, Christian, has just joined us. So welcome, Christian, to the talk. You can keep Afsan and I company throughout this time. Now, for those that are joining us or watching the YP Speaks session through our Google Plus event page, please feel free to drop in the call if you'd like to join us live on the discussion. Otherwise, we can be reached through the question and answer app to contribute in that manner, and through our Twitter handle, both myself at Desiree Neufeld or at NCD Action, alternatively for the network connection. This YP Speaks session the two upcoming sessions are quite special. We're piggybacking on a topic and have, with that said, I'll remind people that are trickling in on the call to mute your mics just so we don't have any feedback to our guests, and we'll move forward from there. So today, which marks April 27th. Yes, it is still April. We have Asa joining us from Harvard. So she is currently a research associate with the Global Health or Harvard Global Equity Initiative, and coordinator as well of the Global Task Force on expanded access to cancer care and control. She formerly served as HDI's research director and currently manages as well the work on women, health and equity, pain control, and palliative care. Alongside her efforts at Harvard, Asa is currently a PhD candidate in health systems in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health, focusing on bioethics and health economics. She holds an MS from the Friedman School of Nutrition Science and Policy and a BS in Biology and International Relations from Tufts University. So with that short introduction, perhaps I'll pass the figurative microphone over to Asa at this time, and you can introduce yourself. If there's something I've missed, please feel free to add that, and I will set the stage for you. So thank you so much for joining us today.
Thanks so much, Desiree. Really a pleasure to be here, and I'm thankful to YP and the whole group for inviting me to partake in this. Thank you for the introduction. Certainly very complete. Only thing I'll add to that is that we are currently at HDI hosting or housing a task force, a commission, a Lancet Commission on pain control and palliative care, and so I'll speak a little bit more to it. And I manage that work with our director, Felicia Knoll. So that's the only other thing that I wanted to add, because it's a core part of what I'll be presenting on. But it's great to be here. Should I maybe switch over to the slides here, perhaps? Okay, just let me know if this does not come through. I apologize. We did run through this carefully before, so hopefully this will work, and we won't have any issues. Okay. Oh. Can we see it?
Yep, you're good to go.
Perfect. Okay, so as Desiree said, I will be speaking to you about the topic of pain control and palliative care, particularly focusing on low and middle income countries. And so let me start with the current status of pain control and palliative care globally. So just to start with some statistics, about 83% of the world's population, and that equates to about 5.5 billion people, has limited or no access to pain medicines. And when you think about it, flipping it the other way, only 7% have adequate access. Somewhere in the middle, there's those of moderate access to pain control and palliative care, but the majority of the world's population does not. And when we think about particular diseases, about 5.5 million terminal cancer patients and 1 million end-of-stage HIV patients suffer from moderate or severe pain. Needlessly suffer, I think that's the operative word there. Now, in terms of high-income countries, they make up about 15% of the world's population. However, 95% of global morphine consumption is within these countries that only make up 15% of the world's population, which is quite a staggering figure. And only 20 countries have integrated palliative care programs within their health systems. So why is this an issue when you think about different health topics and priorities? Whether it's HIV in terms of ARVs, chemotherapy drugs for cancer. These are very costly medicines, but majority of pain medicines are off patent and they're inexpensive, but they are high cost in poor countries. So a monthly supply of morphine is about $60 to $180 US dollars, compared to many parts of the world in high-income countries, about $1.80 to $5.40. So the contrast is pretty stark. I'm going to show you this image, which I think should illustrate really what we're calling the pain divide, which is the lack of access within and across populations to palliative care. And what you'll see here is, given the figures that I gave you just now, North America blows up in the map there. You'll see that the morphine equivalent opioid consumption per death for HIV or cancer and pain when you're contrasting between countries. So in the US, you have 355 million milligrams, in Canada, and then US 333. Europe, less, but about 144. The map is still holding some of its, retaining some of its shape. You see South America as a sliver. Africa is mostly disappearing there, and India is that tiny little sliver that you see. And when you look at the numbers, India is only about 467 milligrams. And I hope that the image there, I want to pause on this for a second, how majority of the world, and that is disappearing, and that is low and middle income countries. They are not even, they're barely even visible in this map. And that's how stark the poorest 10% versus the richest 10%, you can see the dramatic difference between countries. So these are data actually that came from analysis done with, collaboration with Treat the Pain and INCB. You can check out more information about Treat the Pain. They're doing incredible work on the ground. So I wanted to touch initially a bit on the theoretical and so the ethical aspects and implications of the pain divide, and I'm particularly focusing on justice. This is the topic that I work closely on in terms of my doctoral work, but also what we do at HDI. And the issue of pain and the lack of pain control in palliative care has, if we think about different features of justice, it goes across these various features, and I think first and foremost is an issue of respect for the individual and patient, in that we have to think about dignified life and death, and I think this starts from wherever the individual enters. When you think about the health system, enters the health system, the point of care, and throughout so if they're diagnosed with a particular illness, from the point of diagnosis through the end of life care, through the end of life, that spectrum, the life continuum and life course, the care continuum and the life course, we have to think across these dimensions. And dignity has to play a role in every aspect when we're thinking about the health systems and care that is being provisioned. So it can't just be about treatment. We have to think across the course, across the care continuum, and I'll get to that diagram in just a moment. The other aspect is the ethical responsibility of the system. So there has to be fairness in process, and I think that's a component that we sometimes think about. And there are certain guidelines that are out there. WHO actually published a report on making fair choices with regards to universal health coverage, and how do we improve decision making to make it more ethical. Yet we're fairly behind in terms of thinking about processes from an ethical perspective, in terms of having systematic guidelines that help us think about, well, what should we do? Yes, we have burden of disease. Yes, we have cost effectiveness analyses, but what do they really tell us about in terms of justice and fairness, in terms of procedures, so procedural justice. The other aspect is the distributional, and that is equity, was, of course, being one component of that within and across populations. So what we've just seen the map slide, as well as the figures that I just shared with you, is that there's clearly inequity between countries, within even countries, between the rich and poor, and this is definitely an issue of justice that we have to think about and keep in mind when we're faced with challenges and limited resources and making decisions of what should be addressed. And oftentimes this is either related to health systems issues such as human resources or a particular illness, so horizontal versus vertical issues that come across. So I'm going to just briefly mention here some work that we've done at HDEI. You may have read Closing the Cancer Divide. This is a book and also a report that we published looking at cancer care and control in low and middle income countries. And we tried to look at what were the different components or facets of this cancer divide. And so the cancer divide being similar in the pain divide in that there is the disparities or differentials in cancer morbidity and mortality between the rich and poor. And so the different facets that we explored, one being the fact that there are preventable cancers that are not being addressed, or avoidable cancers within certain populations. There's differentials in exposure to risk factors. The fact that there is, we can address morbidity and mortality, yet we're not. So there's the the preventable, and then also the ones that we can treat, but we're not currently treating. And then there's stigma and discrimination around cancer, just as there was with HIV. And the fifth facet that we discovered was really around the pain control and palliative care aspect, and the fact that there's extensive amount of suffering that is happening across diseases. Of course, this particular book focused on cancer. And this really, I want to mention this because this provided the groundwork for why we're working now on this issue, though we went beyond. Obviously pain control and palliative care are not just an issue for cancer, they're an issue for all diseases, and they should be addressed accordingly. And so we started on this analysis to think about where pain control and palliative care fits. And we're thinking about chronic diseases overall. I think this diagram, hopefully, this was actually in the book, and we tried to map out by stage of the chronic disease continuum, so from primary prevention through secondary prevention, diagnosis, treatment, survivorship, and then also palliation, as well as end-of-life care. I want to distinguish here just for a second, a parenthetical comment that we have to be, and as I said before, not think about palliative care just as end-of-life care. They have to be distinguished. We have to think about pain control and palliative care throughout the course of the disease and from point of diagnosis. And so end-of-life care should not be used just as interchangeably with palliative care. But it's in the map. I wanted to make sure that it wasn't taken as that, the way it's illustrated. But what we try to do is map across the stage of the chronic disease continuum, and then think about the health system's functions. How can we think about chronic diseases in a way that is both vertical and horizontal, but also takes account of the fact that when you're thinking about chronic conditions, there's a lot of different stages, and these are prolonged. Treatment can last for longer periods. Survivorship, an issue that is often neglected, and this is, for example, when you think about breast cancer, women, will have mastectomy and they'll go through treatment, and they'll be in remission, but there are psychological issues that come about. They have, they have reconstruction surgery. There's a lot of problems that come across even after a woman has survived from breast cancer, and this can include side effects from the treatment that she underwent. And so survivorship is a key aspect, and then linking, of course, similarly, another neglected area, which I'm the focus of this talk is palliation. So how do we think across each of these stages, across each of these systems from a chronic disease? Because that is, where right now a majority burden we're thinking about the attention needs to focus on, because we've focused on infectious diseases, and now I think we all acknowledge that there's a double burden of disease, and that chronic disease is deserve as much attention, or if not more right now, given the burden of disease. So what is happening in the global front on pain control palliative care? So there was this Montreal Declaration that was put out through civil society calling for strengthening palliative care and thinking about it through having an integrated approach and thinking about it throughout the life course. Last year, WHO passed a milestone resolution, and this was an incredible feat, encouraging countries to ensure access to pain medicines, and thinking about thinking about cross disease. Sorry, there's a typo in there. But it particularly called for integration of palliative care within country systems and made a commitment that WHO would itself provide technical assistance to member states in developing their palliative care services. Further, there's been a lot of discussion as we've gone into the post-2015 development agenda and discussions alongside in terms of developing the Sustainable Development Goals and how UHC, universal health coverage, may be incorporated within that. Pain control palliative care has been brought up as being a specific part of the UHC agenda, and I think we have to think about common causes because, of course, pain is something that all patients suffer, regardless of disease, and I think inputting this into an agenda like the UHC's is critically at this stage. At the country level, I'm just mentioning two examples here. There's various others, but India, for example, is very interesting. India is the leading illicit producer of opioid to the world market. So 90% of the global production of opium is in India. But a majority of its population does not have access to pain control. And another fact about India is that morphine is listed as an essential drug, not only by WHO but the government of India itself. And while there was a drug act of that was brought into effect in 1985, it had very strong regulations in terms of providing access to opioids and for pain control. And recently, in 2014, there was an amendment that was passed that has been another incredible milestone, particularly at the country level in India. And before, the way the regulatory framework was is that hospitals and pharmacies had to go through multiple licenses, and this was across different parts of the health system within India, so different government agencies, and the states had a mandate over this. But with the amendment, the central government is now serves as an authority to regulate with a single license. So, hospitals, pharmacies have to go through so many obstacles and hoops to get these licenses, and not only that, added to the lack of professionals, health professionals, being trained in providing palliative care. This has served a major obstacle. And so the fact that this amendment has passed is a major milestone for India, thinking about how regulatory barriers can be removed because of the fear of illicit use of opioids, which is throughout the world, not just in India. And so this is one of the major barriers that exists. And so we hope the amendment will lead to some concrete actions and impact to patients themselves. In Mexico, as you might have probably read, it's come up in many examples, particularly in terms of healthcare reform, and in addition to welfare programs like Oportunidades, and Mexico in its quest towards UHC, despite its incredible achievements in improving access to healthcare to its population, did not include pain control and palliative care as a key component of that path towards universal health coverage. And so recently with COFEPRIS, which is the regulatory agency within Mexico, they've taken on the task of addressing access to opioids and palliative care overall, but particularly as a regulatory agency, what are the barriers that they can remove in improving access. And FunSalud, the Mexican Health Foundation, in collaboration with HDI, is working with different government partners to develop e-trainings and actually develop a national palliative care strategy for the country, because there is no unified document that provides guidance in terms of how to ensure access to pain control. And so these are just two country examples, like I mentioned. There is progress slowly, but this is just initial, and I think there's a long way to go in terms of actually addressing this pain divide. I want to come to the point of why has this been neglected. When I mentioned the example of Mexico, in the quest for UHC, why was pain control excluded. And part of this has to do with the fact that there's limited value assigned to pain and suffering. And this goes back to some of the comments I was making around the ethical dimension. We value much more extending life and productivity. That's what's prioritized. That's what our measures currently focus on, like cost effectiveness. This is where we've pushed forward in terms of the global health measurement tools and priority setting guidelines. The other is that a lot of patients die. In terms of advocacy, this is particularly a challenge. There's a loss of voice in terms of advocating for change. The topic of pain and death are certainly negative, and they're stigmatized, and so this does not get brought up, and that's why it's an issue that often just gets sidelined. It's not associated with a specific illness, and that I think has a large impact. Oftentimes, if you're thinking about an issue like HIV, or you're thinking about cancer, or you're thinking about diabetes, it's easier to package or easier to sell, I guess, in some ways. There's a face to it. But pain addresses it touches upon touches every patient and every individual at some point in their life, and so it's not as tangible, I guess is the word I would use, and so it has fallen off the radar in terms of priority setting, and the other issues that I think specific barriers in terms of at the country level improving access to pain control and palliative care. One is lack of stewardship, and I think that this is a key component, as stewardship being a function of the system that guides the rest of the functions and both the design and management of the system. That has to be at the core, the central focus if we're trying to improve, or try to close the pain divide, is think about how can we make ministers or ministries of health, think about this issue in a way that they feel like they can address it and that it should be a priority. The others, there aren't adequate regulatory barriers for safe and appropriate handling of opioids. There's a fear of illicit use of opioids, like I mentioned before. There are limited mechanisms, financial mechanisms, to provide coverage. So, as I mentioned, the example of Mexico, the essential package of services did not include, pain control palliative care. There's weak infrastructure in supply chain management. I think this is an issue across, whether you think about diseases or otherwise, in most low and middle income countries. And so, same for thinking about palliative care aspect. Another major obstacle is the fact that there is barriers, that there's very limited training of health professionals. And there's a system, or I should say, fear has been institutionalized. So physicians that are able to or are trained to prescribe have worry about getting into trouble because there are very strict regulations in place in most countries. And so aside from the fact that there are very few professionals who can prescribe to begin with, the ones who can prescribe face challenges as well. I'll give you an anecdote. In Mexico, as I understand it, prescribing opioids, you have to have a paper prescription pad that you can only get from the capital. And so if you're in a rural area, you're a physician trying to prescribe morphine, you only get this prescription pad of a certain number. I can't remember the exact number, maybe it's 50, but you only get a certain number of prescriptions, and only one pad at a time, and you have to go into the capital and pick it up. So if you're in a rural area and you're prescribing, if you're on these pads, you have to make a trip, travel to the capital to pick it up and bring it back, and it is a major hurdle in ensuring, just in terms of logistically, getting patients the prescriptions they need. So those are just an overview of barriers that currently exist. I want to turn now a little bit to what we're trying to do at the Harvard Global Equity Initiative in terms of addressing this issue. And this is just one body of work that's trying to complement a lot of different efforts happening around the world. This is the HDI Lancet Commission on Global Access to Pain Control and Palliative Care. And what we're trying to do here is what we did on the cancer front, which is bring together different communities within we're thinking about health, different health topics. And so global health experts and health systems experts with the palliative care experts, specialists who are not speaking to each other currently. And so how can we have a discourse, interdisciplinary discourse that would get the health systems folks and the global health folks to start thinking about palliative care? And, of course, the goal here is to alleviate, avoidable pain and suffering. And so we have experts from around the world representing many different countries, particularly low and middle income countries. And we have, leading global health and health systems experts who have done work from anywhere from designing, the Global Fund to those who've led health systems themselves. Julio Franco, you'll see in this image here, the former Minister of Health of Mexico. Sir George Lane, the former director of PAHO. We have many leading thinkers here. Dean Jameson, who currently leads the work on disease control priorities, in addition to representing civil society organizations like Human Rights Watch, as well as the International Association for Hospice and Palliative Care. And so this I am going into the detail of this is because you would assume that these, we're having these type of dialogues, but they're not happening currently at the country level or at the global level. And so the commission is about 33 members. Felicia Knoll, our director, and Paul Farmer both chair the commission. The secretariat is at the Harvard Global Equity Initiative, and we have a scientific advisory committee, which includes actually many young professionals who are doing work on this area, and we encourage those who are interested in this topic, and particularly those who are already working on this area and have expertise to get in touch so we can involve you in different work that we're doing. One of the things that we want to come out of this commission is that it's not just another report that is published, but rather that the recommendations that come out of this report are taken to action. And so the IHPC, we're working with closely, they're a civil society organization, they will be taking the recommendations of the commission and actually making sure that they're implemented. They're a body that's existed for a number of years. They have a strong presence, across the globe, and they have, a strong presence that I think can move forward the work. And so, there we go. So the commission mandate, what we're really trying to do, and I want to go through this, is one, we want to declare pain control and palliative care as a human right for all, and that it's part of moral imperative to alleviate suffering. That we have to strengthen national and global legal frameworks so that governments can and are able to actually establish policies and programs related to it. We want to increase funding and mechanisms to support in-country efforts, institutionalize and integrate pain control and palliative care into health system strengthening efforts, and mobilize the movement through public awareness by expanding civil society base. So individuals like yourself who are listening on this call, or who at the future who will hopefully listen to this, think about how you can get engaged, and we can push forward this topic, which is certainly one is an equity imperative, as I've demonstrated through the figures earlier. Now, the specific objectives of the commission are try to contribute to this global discussion on UHC and Sustainable Development Goals. We need to start early and really integrate this topic from the beginning while the SDGs are being developed, and make sure that pain control palliative care is included in UHC discussions. We have to promote more further momentum at the country level. So I provide these examples of India and Mexico, and yes, some progress has been made, but this is, again, these are initial steps. There are champions that are moving forward action in many of these contexts, and but we need sustained and prolonged action to ensure that we actually bring about change. The other objectives of the commission, really, in terms of identifying opportunities, is to incorporate the area of pain control palliative care within health reform specifically. So national health strategies, how can we ensure that these documents actually include pain control palliative care? So it's interesting, recently India drafted its national health policy and put it out for public comment. And I was reviewing it and partaking in a conference that looked at cancer care in India, and we actually submitted a comment to which in response to the public comment, and the major issue that we found was that one, there was limited mention of pain control palliative care. And where it was mentioned was only at the end of life stage. And so clearly there is misunderstanding of where this issue should be brought in, the extent to which it should be brought in, and the fact that the definition should be much broader. And again, thinking about pain control palliative care from point of diagnosis, not just end of life care. The other is how can we, achieve effective UHC, and this goes back to the point, the diagram that I put up in terms of thinking about chronic diseases by health systems function and by stage of the chronic care continuum. Now, what I mentioned before in terms of the current priority setting tools that exist, cost effectiveness, goal burden of disease, et cetera, they do not adequately cover the area of pain control palliative care. So how can we develop instruments that include human dignity and freedom from unnecessary pain and suffering? And how can we incorporate or enable policymakers to incorporate palliative care into priority setting? And we're promoting the inclusion of proposals for health systems strengthening to meet disease-specific and overall needs of pain control palliative care. So we can insert this topic into certain disease discussions, whether it be cancer or otherwise, and at the same time think about it on a broader level. And then we want to provide recommendations for what innovative strategies exist to harness national and global platforms. So some countries are further along the trajectory than others. I mentioned at the beginning there are about 20 countries, only 20 countries that have integrated palliative care strategies. So how can we learn from these countries and others who are in the trajectory towards achieving that and share these and have an exchange of these strategies? So I'll end it there and just leave some time for question and answer. I think I might have gone over time. I just realized. I'll turn it over to you, Desiree.
That's not a problem. Thank you so much for that, Afsa. That was absolutely a great overview. While you are getting settled as well, I'll just remind those, we have a few viewers that I will encourage to use the question and answer box to, I guess, contribute to our discussion, which we hope to have over the next coming minutes. In light of time as well, we'll be sure to release you thereafter. But thank you, Afsa, for that. It was just a great, I guess, start to this mini-series on pain and palliative care, and just facilitating dialogue to, I guess, show and encourage people to begin the discourse of how to enable palliative care and pain control, or what instruments can be used, what countries have been successful. I was very struck by the statistic you just mentioned again at the end, stating that only 20 countries so far have integrated palliative care and pain control into their healthcare systems and their policies around that. So at this time, I know, Christian, you have a great background, so perhaps I'll get those that are sitting in on the call with us to introduce themselves, and just encourage you to have a dialogue together with Afsa, and yeah, we can move from there.
Hello.
Hi, Christian.
Hi, Afsan.
Nice to see you.
Nice to see you, and thank you so much for the presentation. And it was really impressed, and I'm so happy to work with you and with the HDI team, and especially Felicia Knoll as the leader for this commission. I would like to ask you said about only 20 countries have been able to integrate palliative care in the public health system. So among the 20 countries, is any low and middle income countries among the 21, or it's most of them come from the high developed countries?
That's a really good question, and I think that's important when we think about what strategies or innovative examples exist. Costa Rica is a great example, and I think that's it's a small country, middle-income country, and I think they have done an incredible amount in terms of integrating, and they have an actual strategy that is the National Palliative Care Plan that they implement. And Panama, I believe, is one of the other countries that also has. So there are yes, there are, to answer your question, there are certain countries from LMICs within that 20, that figure. But certainly not where we need to be, and that number needs to rise. And I know, I think extensive amount is being done in Rwanda, which you're going to be speaking about in the next session. But thinking about the trajectories that different countries are at. Do you want to add a little trailer so that people view in when you're speaking next time of what's happening in Rwanda?
Oh, we started already 5 years ago to try to integrate it in our public health system, but as we said, there are different challenges. But at least we are on the way of fully integrated in the whole public health system. So I would like just to know if it's only from high incomes countries already developed the program, or there is some low-income countries maybe we can learn from their experiences.
Yeah, no, I think there's a couple, just as I mentioned, that have integrated, but certainly not the figure that we need to be at. But there are many who are on the path, just like Rwanda, and I think that's an exciting time, an opportunity to push forward that effort. What you're doing on the ground, Christian, and many others, and through the leadership of, of course, Minister Benegwaho, it's incredible what Rwanda has achieved in many areas in terms of health, but what you're trying to do right now in pain control palliative care.
And one of the comment, and thank you to mention that about the difference between palliation or palliative care and end-of-life care. Mm-hmm. I think this is one of the misconception among most of the health professionals, and most of people think that palliative care is the fifth wheel of the carriage of the health system, which is not. So I'm really, I was happy when you mentioned that about the terminology palliative care and end-of-life care. So I'm so happy for that. And one of the questions is, from your own experiences, what is the most challenges, especially for low, middle, and income countries, to integrate palliative care or to make pain control access in the population? What is the main challenges?
I would probably say two, from my understanding. And again, this is, I'm not a palliative care expert, but the work that we've been doing in trying to understand the global level, the two main are regulatory barriers. The fact that there are, as I mentioned in India, the incredible hurdles and obstacles, hospitals, physicians, pharmacies have to face in being able to prescribe, and the other being training. I think the lack of training, there isn't in the medical curricula, for example, in many countries, including India, including Mexico, mention or specific, explicit inclusion of palliative care. And so I think that if we want to actually address, this pain divide, we have to think about how can policy, so the legal frameworks that exist right now, how can these be changed? And policies being able that make it easier for managing and regulating. Of course, yes, the issue of illicit use of opioids is a big one, but that should not mean that those who are suffering with pain from various different illnesses should do that. And I think I really, I had seen these numbers before, but I think it's kind of slipped my mind, and I was re-looking at this, which I mentioned earlier, the fact that India produces 90% of, it's a global production of opium, yet majority of the population does not, have access. Why? And this has to do with regulatory frameworks. And the other, of course, training. So I think we need to work on the training aspect as well, and for all cadre of health workers. But Rwanda, I'm going to sorry for Christian. I'm going to turn the question back to you. For Rwanda, at the country level, I mean, there's of course this varies, and so is that what you are seeing in Rwanda, or is it a bit different?
Oh, it's the same. It's the same. The lack of education, especially among physicians, because only physician can prescribe. Right. Morphine. So I think education is among one of the challenges.
Yeah. I want to put a plug in for Christian's incredible article, which I know has been put up by YP CDN, but that Christian wrote actually very recently, very moving and powerful piece about in a post-genocide society and the thinking about dignified life and death and thinking about palliative care within that context. I think we need more analysis like this. And Christian, I really am so grateful that you shared that, have written that, and I hope that everyone will read this if they haven't already, especially before Christian speaks, because I think you'll understand, the perspective which he's coming from.
Oh, thank you, Afsan. I think I mentioned that on the article about we
Yeah.
need more evidence and research, especially for those patients who has really a background from the genocide. We need more evidence based. Then we can show how we can change the way we manage those patients, which is different for other patients we have with life-limiting illnesses or life-threatening illnesses, which is really needed, especially from Rwanda. I don't know for other countries, experiences from Rwanda maybe can be shared for
Right.
other countries.
Yeah.
No, Afsan, I want to thank you for calling attention to Christian's article as well. I was going to actually message that, so that's great. I guess a thread into our next session, and it's beautifully written. I thank you as well, Christian, for sharing that with me. It was very well worded, and it definitely threads on the humanistic and that that side that isn't necessarily talked about in academic articles readily. So it's an important conversation and a piece to add to this topic in general. I'll ask whether both of you have anything else you want to contribute. Unfortunately, it seems that our audience is quiet this afternoon, and we haven't had a lot of, I guess, additional feedback from our viewership body, but I will encourage anyone who is watching this broadcast to reach out on Twitter or by email, depending on how you're connected to YPCDN. Our Twitter handle is @NCDAction. Both Christian and Afsa can also be reached in that method should there be any follow-up.
I think, thank you, Desiree. It's been really great to be on here, and I really want to commend YPCDN for bringing this topic to light and including it in your discussions and in YP Speaks, and particularly, allowing a chance from taking both the global perspective as well as we'll hear from Christian from Rwanda on the ground. Just in terms of how people can get involved, I think that's usually a question at the end of something like this is, go sign the Montreal Declaration. We need more signatures. Okay, what else can you do? We're doing various different activities on the ground through partners, but also at the global level. So, feel free to reach out to us. Various different organizations are trying. IHPC is doing incredible, as I said, in terms of actual implementation. If you want us to link to particular country level folks, please let us know. So various ways to get involved. So please do. There's ways to incorporate this in any area of work that you're doing within health. That's all I'll end with.
That's a great closing statement, and perhaps Afsa will encourage us to collaborate together after this, and we can disseminate both Christian's article before the next session, and perhaps create a piece, I guess, a point of reference for those that are looking to take the next step to get involved, to sign the Montreal Declaration, as you stated, we'll be sharing that hopefully through all of your channels as well as the YPCDN webpage. So please follow up on that. And I'll mention as well that Christian will be joining us the week of May 11th, so stay tuned for that posting and details to follow thereafter. So thank you both. Oh, yes, of course.
One thing I forgot to say is that we have a commentary in the Lancet that if you want to read more about the Commission, there's a commentary in the Lancet that came out in March. So we'll share that with Desiree, and she'll distribute that. But just wanted to mention if you want to read further on what we're doing.
That's awesome. Thank you so much for that.
Thank you, Afsan.
Resources will be provided and disseminated after this. So thank you for those that took the time to view in and those that will be watching this thereafter. It's a great piece and an important conversation to add to its momentum or the continual growth that it is seeing, and a pivotal piece in chronic disease in the continuum. So thank you both for joining us, and I look forward to our next session.
Thank you.
Thank you.